Hello, dental online trainers, and welcome to the Dental Online Training Sharecast. I'm your host, Dr. Dennis Hartlieb. Each month, we'll talk with dental experts who are doing amazing work in the world of dentistry. Also, occasionally, I'm going to throw in a few of my solo-bodied Sharecasts, where I share a little with you about what I've learned along the way during my career. So tune in the first Tuesday of every month to hear the latest episodes. Hello, dental online trainers. It's Dr. Dennis Hartlieb back with you again for another of our wonderful Sharecast episodes. And today I am delighted to have a friend with me, an oral surgeon who's beyond an oral surgeon. We'll talk about that in just a moment. But a friend of mine, Dr. Brian Shah, who's coming to us from Florida, but was practicing in Chicago for a good amount of time. And that's when I got to meet Brian and get to work with Brian while he was here in Chicago. For those of you who do not know Brian, as I said, he's practicing down in St. Pete area of Florida, and his practice is limited to TMJ reconstruction and facial reconstruction for patients with facial anomalies, facial deformities. We're going to talk a bit about that, but Brian has a really interesting background, and I don't want to say he had challenges, but he had some changes in directions in his professional practice stuff. And I think that's super interesting. And that's actually why I brought Brian in. Well, we'll talk a little bit of the stuff that he's doing because that is super interesting and fascinating. In fact, I just sent a patient down to Brian because she's had some changes in her occlusion, significant changes in her occlusion that I'm very strongly believe is related to some joint breakdown stuff. And so we'll touch on that also. But first of all, it's important that I recognize, and if you're watching this on the YouTube video, you'll see I'm wearing my Michigan hat because Brian is a Buckeye, and so I had to wear. Well, he went to Ohio State Dental School, but let me tell you a little bit about Brian before we do all that. So, Brian, you grew up in Chicago, but then first of all, let me welcome Dr. Brian Shah. Everyone claps.
Thank you, Dennis. It's great to be here.
Thank you for joining us. So, Brian, you were born in Chicago, but you grew up in the Cleveland area. And I think, did you end up going to Case Western for your undergrad? Is that what I remember?
No, I actually went to Miami of Ohio.
Oh, that's right. Okay, one of those Ohio schools. I remember that. And then you, what was your studies in your undergraduate?
So interestingly, I was just talking about this in the operating room yesterday. I started college as a fine arts microbiology double major. And the fine arts part was really, I wanted to explore it because I loved it in high school and I always had been sort of inclined as an artist. And I started, and very quickly in undergrad, I realized this was not going to be the way I keep the lights on. I loved it very much, but I think the professional prospects were limited.
Were you painting, drawing? What type of fine arts were you?
So both, but pen and ink type art was where I really excelled and what I really loved to do. So it's funny how just like anything else, though, you have to practice. I used to be able to render anything I looked at, and now sometimes if I'm playing Pictionary at Christmas with my family, I'm like, wow, what happened? It's not what it used to be. But, I plugged along a little bit in undergrad and then really shifted my efforts into the sciences. And I truly loved microbiology. For a period of time, I thought I was going to just be a lab researcher and get a PhD and work that way. So it was a lot of fun for me.
So what was it that motivated you to sort of seek out dentistry? How did dentistry find you? How did you find dentistry?
It found me. And this is truly the way it went. I underwent 2 jaw orthognathic surgery when I was a sophomore in college. I had a pretty significant class 3. And so they widened my maxilla and advanced me with a Le Fort, and then did a minimal setback with the mandible. And boy, I was beat up, but it was life-changing. It was something that I would do again tomorrow if I had to. But, that was, I guess, 1993, maybe between 93 and 94 when I had that done. James Smith at the Cleveland Clinic did it for me, did a great job, but they had bad splits in both mandible. They had to wire me shut for 8 weeks. I was transfused 2 units of blood, spent 4 nights in the hospital. But it was still such a positive experience that I said, that's what I want to do with my life.
That's crazy. I mean, that's so fascinating. First of all, how that experience impacted you in such a positive way, and in a way that could be such a negative experience, right? Because of all the pain and suffering from the post-op surgery. Before that experience, had you been thinking about dental? Had you been thinking about medical? Had you been like toying with those ideas?
Yeah, and I have to admit, medicine has always been, and science, something that's always been pretty strong in my family. My dad's a PhD medical engineer, and my mom's an organic chemist. And, from my last name, I am part Indian. My dad's from Bombay. My mom's Italian. And in the Indian culture, especially immigrants, medicine is everything. So we used to have a joke in my family that, my dad would say, okay, you can be an artist after you get your MD. You've got to do medicine. So I kind of put that together and said, well, wait a second, there's another way of getting there through the dental world, which allows me to be both a dentist and a physician. And this is just fascinating. And that's really what perked it. So yeah, to be fair, my family was pushing me in that direction. My brother's an orthopedic surgeon, Michigan. So the family's balanced.
There we go. All right. All right. So now we know where the brains are in the family.
Yeah. Well, right. There you go. And that's probably true. But so yeah, I think culturally and from a family perspective, sciences were always near the top.
When you started applying to dental school, were you also thinking med school at all, or had you just sort of said, I want to be able to do this facial reconstruction stuff, I want to go towards the dental route?
Yeah, I was super focused on dentistry in undergrad. But at the same time, I knew before I started dental school that I wanted to do a combined maxillofacial program. And I thought it was essential to get my medical degree as well, really because I didn't want any doors to be closed. And I figured, listen, these guys can get me a medical degree in 2 extra years, 6 years of total surgical training versus 4. And if, who knows, politics change or I move to one state versus another, everything is covered if I have my MD.
Now, let me ask you about dental school. So before you started doing that, so you went to Ohio State for your dental school experience. So when I went to dental school, I wanted to drill teeth. I would just want to work on teeth. So asking someone who had expectations of doing something beyond just working on teeth and doing, jaw reconstruction, stuff like that. I don't want to say were you bored, but did you find that the restorative stuff of dentistry, were you just like eager to get that out of the way? Were you like, gosh, I can't, I just want to I guess my question is, we all had to go through the same training in dental school. Did you enjoy the restorative end of the dental experience? Did you enjoy the prosthetic end of the dental school, or did you just see past that and knowing that, hey, I just want to get to the oral surgery aspect?
That's a great question. And fortunately, I really, really liked the restorative side. Believe it or not, one of the things that I loved doing more than anything was waxing teeth.
Okay.
And that was sort of the way I would study. Is I would get home from school, eat, go run, then I'd go to the library and I'd bang out, the memorizing biochemistry and all of those things. And then I'd sort of grab a big cup of coffee and end up in the pits, the lab, and go down there and wax teeth. And I had a couple dear friends who loved doing it as well. They're both general dentists right now. And the 3 of us would kind of hang out in there. We'd trade music. We'd be in there late. You'd almost have to drag us out. So I really, really, really loved that aspect. To be honest, though, I'll say as things went going a little, removable pros I found to be difficult. And At Ohio State, we had very traditional training in that regard, and there was a little bit of this hazing, where the teeth would pop out of the wax, and you'd have to pick them up on the floor as your professor was telling you got to redo this. So I think that was a little tough, but at the same time, all of those things are required. I mean, it's funny now that I don't take out teeth anymore. I don't put in implants, but I use occlusion in dentistry more than I ever have as a general maxillofacial surgeon.
It's so funny. I think, you have these strong instincts, right? You have this fine arts background, you have this fine arts love. And I think that's one of the great things about restorative dentistry. And I didn't have any of that skill. I'm not an artist at all. I liked it and I appreciated it, but I didn't have those natural skills. But certainly being able to do your wax ups, that I think allows you to have that artistic part of, what was inside of you, right? That you still had that in you, and you're able to bring that out while you're doing your wax ups and stuff, right? And that brought you probably a lot of enjoyment.
Absolutely. And there's sort of that physical side to creating. And, they talk about that in different business books and books on excellence, getting in the zone where time just goes by and you don't realize what you're doing. And for me, that's the way operating is right now. So yesterday I operated straight for 8 or so hours. I did 2 bilateral joint cases. And if you were to say to me, okay, Brian, it's 5 a.m., you got to go to work and work continuously for 8 hours, if I had hair, I'd pull it out. I'd be miserable. But going and actually operating and tying knots and dissecting through tissue and creating sort of these things that we all create in dentistry, oh man, the time just flies by. It's great. And I hope physically I can do it for a long time.
I feel the same way when I sit down and do like a composite veneer case, and it's six teeth or 8 teeth, and we get started at 7 or 8 a.m. and we just work straight through. We give the patient a break here and there, but we're just, we're banging it out for 6, 7, 8 hours. It's lost time. Like if I didn't have a hygienist that was actually bugging me to go do a hygiene check, I probably wouldn't stop, and I wouldn't even know it, because you just, like you said, you get in the zone, and you just sort of get to create, and just you sort of get transformed.
Yeah, absolutely.
So you're going through dental school. It's so funny you talk about the removable pros challenges and the hazing from, collapsing your articulator and watching the teeth, bounce around on the floor. Besides that, any challenges you remember from your dental school days?
Well, I do remember when I started spending a lot of time with the oral surgeons. So I was lucky enough at Ohio State, they had a program where they would pick 2 people out of all the applicants to have basically a golden key to the oral surgery department. It was called the Arden K Hegtvedt Award. It was named after a wonderful oral surgeon that unfortunately died in the clinic, a very young man. But Dr. Peterson, who was our chairman and a huge mentor of mine and someone I just looked up to, put this together with the other people in the department. And I won this with another classmate of mine. And we got to spend a ton of time with the oral surgeons and just be there and watch them operate and do research with them. And I do remember, as I was progressing through the years, watching how hard the residents worked and seeing them come back into the resident room after being up for 24 hours and having to write a bunch of notes and then study for grand rounds the next day and all types of things. And I did have this little panic where I was like, do I really want to do this?
Right. Yeah.
It's sort of all of those other aspects of life that I enjoy so much, I kind of had to realize those were truly going to be gone for 6 years. During this program, it's just not going to happen that you get a chance to do a lot of these extracurricular type things. So that was a little bit of a gut check to say, okay, am I going to do this and am I ready for it? And even though I truly thought I was, it didn't prepare me for the reality, which was so much harder than I thought. So,
Yeah.
but you get through it. We all do.
Was the Ohio State oral surgery program, was it through the hospital? Did they have like a clinic in the dental school, but then they also had something at the U hospital, or how did that work?
It was a very, very strong dental school based program. One of the, if not the best, one of the best in the country. And Harvard was very different than that. Even though the dean of HSDM when I was there was Bruce Donoff, a prolific oral surgeon in our department, we were hospital based. So our oral surgery program at Mass General was at Mass General, and we briefly would swing by HSDM every now and again. And Ohio State was the polar opposite. I mean, you were ingrained with everyone, periopath, restorative. You were right there in the clinic with everyone. And I think that's an advantage. That's a good thing.
Yeah, I was going to ask you about that. So when you're hanging out there with the oral surgeons and stuff, and you're going through your undergraduate, you're getting you're getting all your reps in, you're getting all your procedures completed and stuff like that. And so you're sort of like, kind of like the bat boy, right? You're like sort of hanging out with the big leaguers and stuff like that, and just sort of, poaching on sort of them. Was it difficult for you to engage with the faculty and for the residents and stuff like that as an undergrad dental student when you're going into that clinic and stuff? Or did you just sit there like a fly on the wall, or how did that work out?
So I think that's a testament to the professors that we had at the time. We were integrated and they expected you to participate. Dr. Peterson would make a point of kind of bringing you into it. The residents would go up and present a case and talk about things that were way, way, way over my head. But he would say something like, Brian, do you see on this panoramic image that there looks like there's metal floating between the maxillary and the mandibular dental arches? What in the world is that? What is that? And I'm sitting there thinking, and it made you think, oh my God, that's a substructure of some sort of appliance. And we can see that on the film, and it should have, so that's something that all of the residents in the room knew. But he would make a point of kind of bringing and engaging us as dental students and bringing us into the conversation. So no, I think that if you were willing, meaning if you weren't too afraid to be amongst these guys, they're going to let you play, and they'll let you be part of it.
If you're a dental student and you had to give advice to a dental student who wants to go on and do some sort of post-grad program, oral surgery, ortho, pros, whatever, what would be your recommendation on, any given dental school? Like I want to go into pros, and I'm at, say, Marquette Dental School, for instance, and I'm a D3, third year. What recommendation would you give for them to like get your foot in the door? If you wanted to get into endo or whatever, how do you go talk to the faculty? Like, hey, I want to learn more. I want to see more. This is something I'm really interested in doing in the future. How do you make that? How do you introduce yourself, do you think?
It's interesting because I also have that perspective of being faculty when I was at Yale. And I'll tell you, it's being genuine. That's the key. People can tell if you're going into a department to sort of rake up information and pad your resume, and you don't really in your heart think that this is something you love or something you want to do, the faculty will pick up on that. And it comes across as being a little shallow. So I think you want to, number one, you have to physically be there. You've got to put in the time to be there. But then you really have to express what makes it exciting for you and why you're interested in this particular field. And, don't tell them what you think they want to hear, or just tell them what you really think, and they'll sense it. So I really think it's persistence, it's being genuine, and there is a level of respect that you need to adhere to. And I know times are changing, and things are becoming more casual. But boy, I will tell you, I would never go up to Larry Peterson and pat him on the shoulder and say, "Hey, what's up?" You don't do that. That just doesn't happen. You show your respect for not just them, but the entire profession, and it'll come through.
Yeah, I think it's really sort of just getting up the courage to get there and express that, right? This is something I'm really interested in. I'd like to learn more. I did that at the Prost department when I was at Michigan. And I just sort of like, one of the instructors, I said, do you mind if I just come by? And, and he said, sure. And so I just sort of showed up one day and just tried to, and I continually just went there and just to, see if I could just overlook what they were doing and just ask questions. And it was very formative for me, but you have to have a bit of courage, I think, to be able to do that. It's kind of intimidating.
Oh, it sure is. I mean, that is kind of the hurdle number one of this very long road of getting to where you want to be is putting the fear aside and doing the things that you want to do and doing it in a genuine way.
I remember I wanted to understand D-vital bleaching. And so I went to the endo department and said, could I just assist on one of the endodontists, one of the students while they're doing a D-vital bleaching case or a couple, so I could just sort of understand what they were doing and be able to sort of pick their brain on and stuff. Because we obviously wouldn't have any experience with that in the undergrad. And they were very welcoming. And I just literally sat chairside and I suctioned and just sort of got to sort of see the technique and talk to the guy, the resident that was doing the case. And it was great. But you have to sort of put yourself out there a little bit, I think.
You do. And I did do that. At home over the summer, I went and hung out with the oral surgeons at the Cleveland Clinic. I ended up doing an externship at Case. And, you just go and you follow everybody around and get involved and try to be useful. I think that's another thing that maybe people in a situation where you're an undergrad student, you think you can't be useful. You can. There are lots of things that you can do to make people's lives easier, and they'll remember you for that, and they'll like you.
Yeah, absolutely. We were just recently talking to Nate Lawson, who's at UAB for research. And so we talked a little bit about also sort of people coming in and, be useful, right? Make sure that we're, you don't want to just be getting in the way. You want to see what you can do, even if it's just sweeping up a little mess or whatever it is, picking something up off the floor, just be useful.
Exactly.
So when you're finishing up with your undergrad and then you're off to oral surgery and you end up going to Harvard, what was it about Harvard, besides the fact that they had the 6-year program and you could get your combined MD and oral surgery degree? What else about it that was attractive to you?
Yeah, there were a few things that really put it at the top of my list. Number one, of course, the medical school. The medical school is consistently the best in the world, and they have a very, very unique, inclusive way of teaching. And I truly felt that when
In what way? What do you mean by an inclusive way of teaching?
They break up into very small groups. So you have large lecture series, and this is even from an early level on. And then they break up into small groups, and you're led by a resident in whatever particular specialty you're working on. Let's say you're doing your core GI program, and you break up into a group of maybe 6 people, and you split up all over the school, and their resources are truly amazing. Everything is at your fingertips. Their endowment is huge. So you get a small group, you have case studies that you're working on, and you have someone to lead you through these things. So we would solve biologic problems and diagnostic problems in small groups. And it even so when I did it, we did 2nd year and 3rd year. And so you get your real core training. And it was so cool because you start to play doctor a little bit. You get to say, okay, this guy comes in, he's a diabetic, he has bleeding, he's lost this much weight, his labs look like this. We see this on the imaging. What do you think is going on? And you kind of bat it around the room. So the teaching style I thought was fantastic. The other thing that I really loved is once you're in, they give you a lot of room. I had many classmates that said, I'm going to take a sabbatical and go research or go work in a lab, and then they let you jump right back in where you left off because they see the utility in doing this. So it's a very inclusive way of teaching, and you get this sense as a student that once you're in, you're already in, and they trust you that you're good enough, that you're not going to goof off, and you're going to study, and you're going to do the things you need to do. And so I always say that Harvard Medical School was just a gem in my career and really taught me how to think and solve problems.
So I imagine just incredibly long days. Did you ever have like moments of desperation when you were going through those
Yes.
days?
But more on the surgical residency side than the medical school side. Medical school was still, to a certain extent, very theoretical, and you're on the out, watching. But as a surgical resident, there were times both in oral surgery and general surgery that I was so exhausted. I was truly like, okay, I can't do this anymore. I'm beat. But you struggle through, and everyone around you is going through the same things. Now, as we know, that's not necessarily the safest way of teaching, and we are now at an 80-hour work week, so you can't truly exceed that unless there are special circumstances. And at the end of the day, I think that is good. I've seen people fall asleep in the middle of standing and holding retractors in the operating room, and we really just don't see that anymore. And the research clearly shows that if you're that sleep deprived, it's like being drunk. Make errors with cognition. Your manual dexterity is poor, and we're already talking about people that are not fully trained. So I do think there's a balance. You've got to be there most of your life, but at the same time, the basics of, eating and sleeping need to be there.
I mean, you need to get reps, right? I mean, that's the issue. You got to get the reps, and you have a limited amount of time, but you still also have to be functional.
That's right. That's right. And I think the studies now truly show that it's not just practice, it's high quality practice. And that's where we need to be with surgical training.
Now, is that changing now because you did your program, gosh, is it 20 years ago or so?
Yeah, it was 2000 to 2006.
Yeah. So is it changing? I mean, in 20 years, is it less hours and more compassion to the residents?
Yeah. Oh, yeah. Significantly. And there are forms that the surgical program has to fill out to make sure that they're abiding by these rules. And for better or worse, once things are recommended and adopted, now we start to fall into the liability category. So with liability comes documentation. So the programs are held accountable for making sure that residents are healthy and doing well.
How much have things changed since when you did your program, so 20 years ago, to where we are today?
So I think things have changed not as much as one might think. And I'm going to preface that by saying I think that's good. I think the things that needed to change, changed, but some of the core basics that have been passed on forever in hardcore surgical training, I think it's still there in most programs. I think the one thing that makes me laugh a little bit is technology. At Yale, now we're doing all orthognathic surgery with virtual surgical planning. I do all of my cases like that. I get custom cutting guides. I get custom plates. Right. It's all done on the computer. I'm not making splints, and I'm not using an articulator. But what we decided at Yale is on Saturday mornings, we should have an old school session. So take one case and mount models and say, okay, if we're going to fix the cant in the maxilla, advance it this many degrees, and fix the occlusal plane, how do you do that holding this model in your hand based on a piece of plaster that's cut superior to the occlusal surfaces? And at first, boy, I'll tell you, they're like, what? Because they're not, I think we, as oral surgeons, we need to be able to think that way. Where are you fulcruming the maxilla to accomplish these things that you want to accomplish with everything else. So to hold that model in your hand, you get it. And you also understand how difficult it is to, how do I want to say, sort of project the geometry of the movements. So you think you're doing something, but then you look at the other side of the arch and it's changed by many millimeters because your angle was off by 2 degrees. So understanding that three-dimensional geometry and doing it the old school way is very, very important. So I think, overall, it saved the residents a lot of time not having to do that in the lab. We know that we get better results for sure. And then we're teaching residents how to look at things in 2 different ways, three-dimensionally on a computer screen and then really holding the thing in your hand. And that helps. And I suppose that's in the realm of simulation, which a lot of programs are doing right now.
That's so cool. I mean, as we get more and more digital, the reality is we're still analog, right? We're still using our hands. And yes. I think, we were talking about, I think before we got on, is that, again, talking about reps, right? You're talking about this with when you're drawing, the more you practice, the better you get at it. And, if we're using our hands, and I talk about this all the time with DOT, is that I still do my wax ups. I do my wax ups to help me prepare for what I'm going to be doing when I get into the clinic. And so if I have a 6 veneer case on Monday, over the weekend, I'm going to wax it up. So I know what I need to do for form when I go and do the case on Monday. So I think, as you talk about, just simply seeing how the model changes position, and it may not look like much, but all of a sudden you have a huge, disparity. To see it in your hand, I got to imagine that's really impressive for these young residents.
Yeah, and you always hope that they see the utility, because it is a grunt. They're getting either, they're pouring models. Then you look at it and you say, no, look, man, that you didn't use your whip mix. That didn't mount the way you thought it would. And there's a discrepancy between what's real in the patient and what we have mounted. That discrepancy will then be translated to the operation. And you have to then decide in your head, do I care about 2 to 3 millimeters? Yeah, we should. That's a big deal. That's what we understand as dentists. And I think that's an advantage in craniofacial surgery, having a dental background. It's not good enough to be close. If you can get it perfect, that's where you're going.
Yeah. When you finished up your program at Harvard, did you go straight to Yale for you to take over the program, or did you private practice first?
Yeah, no, this is where my world gets crazy. I went through sort of a journey of private practices. So I studied and was a partner at a group in Portland, Maine. They were all, actually, most of them were MGH grads. And it was an incredibly wonderful, well-established group of surgeons that have been there for 50 years already. I was lucky enough to be invited to join these guys, and it was a great experience. It was a 4-man group where we did full scope maxillofacial surgery. We were becoming sort of a rarity because those were the days when people were starting to say, forget it. I'm not going to go to the hospital anymore. And it's hard to blame them. But we would get cases from across the state of Maine to do ameloblastoma resections and hip grafts and big trauma cases and orthognathic surgery. And that is what I really, really liked about it. And I'll tell you, I would have stayed there, to be honest. But here's where things get tricky in life. And back to your point earlier that none of us can escape reality. The girlfriend at the time that eventually ended up becoming my ex-wife was a Chicagoan and said, I don't want to live up here. I want to come home. And that's what brought me back to Chicago. And then things got kind of interesting. I was interviewing with a prominent oral surgeon downtown Chicago, who I won't mention, at Northwestern, who said, I can't wait to have you. We'll do a 3-year buyout. You'll take over my practice. I'm not doing a lot of orthognathic anymore or trauma, but I'm at Northwestern, so you can do as much as you want.
Right.
And it's perfect. And that was 2008. So the market crashed. And, he said, this isn't going to happen. That I need to work longer until my retirement pops back up to where it needs to be. And I found out that he didn't just work for a few years, he worked for a very long time.
Mm.
So I ended up in Chicago without a job. And that was crazy. So then it started this roller coaster of, okay, what about this? So I could work here for a little bit. I can do implants with these guys. And at the end of the day, it ended up being the best thing I could have done because I learned so much. I was doing all types of full arch implant cases. As you know, for a period of time, I was working with George Mandelaris.
Right. Mm-hmm. That's how I met you, was when you were working with George.
And wow, that's when, I realized, okay, as an oral surgeon, I need to learn more about what my dental colleagues are doing. And George taught me that. George is a wonderful communicator. He gets people together. He builds solid friendships and referral bases, and he's incredibly talented. The other thing I really loved about working with George is he's completely modest. He learns from everyone around him, and that's kind of, the way I feel I've always been. Whether I'm working with an oral surgeon that does implants all day or trauma all day, I've learned from every one of these guys.
Mm-hmm.
And by bouncing around a little bit, I think it's only made me sort of not just technically a little bit better, but I'm more understanding of what all of my referrals need to do with that patient when they're in their chair.
Yeah.
So, oral surgeons have a tendency to say, I'm done. I did my work. You guys take care of it. That's not the end of it. We need to get them to the finish line, and knowing what the other practitioners are doing is super important.
For those who don't know George Mandelaris, he's a periodontist in the Chicago North Shore suburbs. I've worked with George for maybe 25 years. Ever since he got out of school, he joined a practice of Alan Rosenfeld, who I've been working with. And George's a Michigan guy, so we got along famously. But George truly believes in collaborative dentistry with
Yes.
whether it be oral surgeon. I mean, George was not afraid to have an oral surgeon come into his periodontal practice because he recognized that there are things that the oral surgeon could be doing that he's not trained to do, and maybe that he doesn't want to do. And so he wasn't stifled by the fact, oh, there's going to be some competition between me and an oral surgeon. He welcomed the collaboration of that. And he's been that way with restorative dentists and with orthodontists. And he is, like you said, really great at building teams of like-minded people like that. So, and that's how I got to know you, is when you were working with George.
Yes, exactly. And along those lines, words of wisdom for some of the younger people watching this is, at the end of the day, if you work with people and your goal is to get patients better, you will all do well from a financial standpoint. There is no reason to hoard things. It never works out. And what ends up happening is you become a jack of all trades and a master of none. And it's better to be really, really good at a few things and say, listen, this guy down the street, he's your man for that, because I'm not as good as he is, or woman. And you'll do better that way, and you'll be happier because you won't be struggling doing procedures that you don't love.
Yeah, so true. Yes, I agree 100%. That is so true. So that's how we got to meet. And then I think at that point, you probably met Jim Mckee through working with George. And for dental online trainers, you should be familiar with Jim. He's done a couple courses for us, or a few courses on our DOT platform, and he's done some evening webinars and stuff. And if you don't know Jim, Jim is a restorative dentist whose practice was heavily focused on treating patients with TMD or TMJ problems. And so I'm assuming that's sort of where you made a connection with Jim, yeah?
Yeah, that's exactly it. George and I were at, I think it was a Seattle Study Club meeting in Oak Brook. And he said, hey, listen, Brian, I want to take you to this guy, named Mark Piper. He's giving a course with Jim Mckee. And he said, on the McDonald's campus. And so we just drove over there and crashed the party. And that's how it all happened. That's how I was introduced to Mark Piper and really started to become closer with Jim. And that was the missing link. My practice in Chicago was moving towards orthognathic surgery.
That was when you were in Chicago. So that's where you were moving it towards.
Mm-hmm. Exactly. And it was a hard thing to do, to be 100% orthognathic surgery. It doesn't happen overnight. You have to be patient and do the other things, and then eventually you'll get there. And I started discovering some things that were unsettling from a clinical standpoint and from a scientific standpoint. And that was these relapse patients. And I was seeing them referred from other practitioners, and a lot of them from general dentists, who said, I don't know what to do with this patient. They already had braces and orthognathic surgery, and now they have a 6 millimeter anterior open bite. What do? We can't put them through all this again. And that's when it all went towards the joint. And Mark was the missing link. And when I sat down with Mark and spent a little time with him in Chicago, and then I took him out to dinner in Chicago, I came down here to St. Pete and hung out with him. It was like the light went on. Mark was like, man, this is what I've been talking about for 20 years and no one's listening to me. Yeah. You've got to respect the joint. Relapse will occur if the joints break down, and you've got to treat the joint before you do the orthognathic surgery. And that's where it all came together, and it was just a natural fit. Mark said to me, I'm getting into my twilight. I have a 3-year plan. Can you come down here and take over? And he was good to his word. And that was how it all happened.
So for those who aren't familiar with Mark Piper, oral surgeon down in St. Pete. Yeah, St. Pete. And Mark Piper, he sort of wrote the book on joint surgery. And if you are familiar with TMJ diagnoses, I guess there's a Piper classification, a Piper 1 through Piper 5, 5A, 5B. So he's sort of like the guy. I remember introducing Mark at an AACD meeting where he was giving a presentation. I was reading his accolades, and he may have been knighted by the Queen. I can't remember. But so I'm going through everything, and I literally, like, I paused and I deadpanned, after reading like 20 different accolades. I'm like, but then again, who amongst us has not? And I look over at Mark, and Mark's a very serious person, and he did not smile. And
exactly.
But I think it's very interesting. And so I wanted to ask you this, because as I've gotten to understand restorative dentistry better and better, and this has been through really my relationship with Jim Mckee, understanding how occlusion is so joint-based, right? In dental school, we're taught that teeth fit together, and they'll acknowledge there's a jaw joint there, but there's very little, right? Centric relation, centric occlusion. That's what we know about the jaw joint. And so you want to set your case in CR. And I mean, that's really about it. Maybe a little Bennett shift, and there's very, very little. But that is all about healthy joints, which is, a percentage of the patients we treat, but there's a big percentage of patients that we treat with unhealthy joints, or joints that are not fully, or say discs that are not intact and not fully healthy joints. So how is that possible in surgery, in oral surgery, when, like, I mean, I'm astounded that you would go through a program and that the connection isn't there between what's going on in the occlusion, what's going on in the joints. How's that not so prevalent? I mean, I'm blown away by that.
It still remains amazing to me. So I presented on phased surgery at the American Society of TMJ Surgeons last year, and I was met with a lot of hostility. I really, really was. And I'm saying, wait, and I started my talk with a paper from an oral surgeon that I have the utmost respect for, which is Larry Wolford. Dr. Wolford has given our profession so much because he's done a lot of research. He was one of the first ones that said, don't be afraid to do counterclockwise advancement of the maxillomandibular complex, or if you have stable, healthy joints. And so I started my talk with that. And I said, Dr. Wolford's known this for years, and his approach has been to use the MyTech anchor technique and fix the disc and then do the orthognathic surgery. And even with that, I think it didn't sink. And it was sort of saying, are you crazy? You want us to do what? And we all know in maxillofacial surgery that when you're doing a sagittal split, or even if you do a Le Fort and you're rotating the whole complex up to plate the Le Fort, the whole case is based on the TM joints. And if that proximal segment is in the wrong position, whether it's underseated, overseated, etc., you're going to have relapse, and then you're going to create pathology within the intra-articular function of the joint itself. But it's been ignored to a certain extent because I think it's so hard to deal with. And people have tried to write papers on this. Use an ultrasound intraoperatively to make sure that you're seating the condyle where it should be. That's one concept that came out. The Europeans, for a while, what they would do is they would take a bite in what they would call centric relation once the patient is asleep, put the blue bite in the mouth, wire the patient into the blue bite, plate the proximal segment of the mandible to the zygoma, then do your split, and now you know that your mandibular position is exactly where it was when you started. So we know, subconsciously or consciously, we know that that's the weak spot in orthognathic surgery. But the way that Mark kind of looked at it was, we can do so much better than that by actually looking at it with imaging and then trying to stabilize things ahead of time. Now, what I've done with my orthognathic surgery is, with the guided cases, having a custom plate, I know my proximal segment is exactly where I wanted it to be on the computer. Otherwise, there's no way it would fit.
To pause, when you say imaging, you're talking about MRIs.
Yeah.
To be able to evaluate the disc position, the disc health, and then now using CBCTs to be able to see the health of the bone, the shape of the bone, stuff like that. So using this sort of imaging to have a much better sense of what the joint looks like, what the joint space looks like before you even get into the surgery.
Exactly. That's exactly right.
Hey, listeners, this is Dr. Dennis Hartlieb dropping in to let you know that this is actually a two-part interview with Dr. Brian Shah. Well, thanks for listening to part one of this great conversation with Brian. And if you want to learn more about collaborative dentistry and our experiences working together, join us in 2 weeks when we'll be dropping part two of our conversation. So thanks again for listening. Yours for better dentistry. I'm Dr. Dennis Hartlieb. If you enjoyed this and you want to get more information from dental online training, then check us out at dothandson.com. That's one word, dothandson.com. Now, as a reminder, DOT has so many other great opportunities for your learning. We have our Wine and Unwind monthly webinars where we engage real time with our viewers as we bring in leaders throughout the dental industry to bring you up-to-date information and answer your questions. We have our monthly Coffee and Donut Study Club sessions where our participants bring in cases and we treatment plan these cases together to help you with the dentistry that you provide for your patients. We have our live virtual workshops where our dental online trainers perform the same techniques from their kits in the comfort of their own home or office as I'm doing the same procedure under our video camera. We have our blogs and we have an endless selection of hands-on pre-recorded technique courses to help you improve the quality of the clinical dentistry that you provide for your patients. That's right, with our on-demand courses, you do these hands-on exercises when the time is right for you. So check us out on Instagram, Facebook, or LinkedIn at Dental Online Training. And hey, be sure to share this with your friends and colleagues who you think might benefit from this Sharecast and everything that we have to offer with Dental Online Training. And hey, how about one of those coveted 5-star ratings? We would love it and appreciate it if you could take the time and just give us one of those great 5-star ratings. This episode was created with special help from Claire O'Neill. It was edited by Ashley Dickinson Ellison and with original music by Chris Peterson. Again, thank you for listening. I'm Dr. Dennis Hartlieb, yours for better dentistry.